Good afternoon, everyone. Welcome, and thank you for coming to HealthyU. My name is Dr. Jeffrey Visco. I am a board-certified colon and rectal surgeon. I also serve here at Colorectal Health at Millard Fillmore Suburban Hospital in the capacity of the Site Director of Surgery. I'm going to get started with what we're going to be talking about today, which is colon and rectal cancer, a subject near and dear to my heart, as I have been a colorectal surgeon for the last 20 years now. Colorectal cancer is an incredibly important topic. It is the third most common cancer worldwide in terms of incidence, and it's the second leading cause of cancer-related death worldwide. Kind of scary stuff. I'm going to be talking to you about the good news first, because I'm a positive person and I like to get good news first. The good news is over the last 20 years or so, the death rate for colon cancer is actually decreasing. The reason is incredibly related to screening. Screening for colon rectal cancer is an incredibly important thing to do. As we just came out of Colorectal Cancer Awareness Month in March, really vital that everyone gets screened for colorectal cancer. Good news as well is that there are multiple different ways to get screened, and I'll be covering that in a bit. I also have some kind of good news about some clinical trials that we're doing here at Millard Fillmore Suburban and Colorectal in general that we're very excited about and may change some of the treatment for rectal cancer significantly. We do have some bad news in terms of risk factors. Unfortunately, in the last several years, we've had an increase in the number of below 50-year-olds that are being diagnosed with rectal cancer and colon cancer. Because of this incidence rising so much, they've actually decreased the screening age from routinely 50 years old down to 45. That is a direct result of this trend that we have been seeing. We're not exactly sure why that is, but I'm sure it's multifactorial. But please, if you have no family history, 45 is the new 50. Family history is one of the prime risk factors for developing colorectal cancer. And what we mean by that is either a colon cancer or an adenomatous polyp occurring in a first-degree relative, less than 60 years old, or two second-degree relatives, meaning aunt or uncle, grandmother, grandfather, at any age of the occurrence. So it doesn't matter when the polyp was, as long as there's two second-degree relatives. Familial adenomatous polyposis, which is obviously a mouthful because I couldn't pronounce it. You should start screening around age 10 to 12. That's a genetic syndrome where there are carpets of polyps. Can be a de novo disease, meaning that you may be the first person in the family, but in general, there's a significant family history of familial adenomatous polyposis. Lynch syndrome being the third thing in family history, which causes risk. Lynch syndrome, you should start screening between 20 and 25 or 10 years prior to the first case of colon cancer. Lynch syndrome, also a genetic disease, which includes other cancers such as uterine, ovarian, and some of the renal cancers as well. So you'll get a history of that. Those people should be screened earlier than the 45 recommendation. Moving on, inflammatory bowel disease, and including ulcerative colitis and Crohn's disease also increases your risk. So those people should be screened earlier as well as more frequently. Lifestyle risk factors include smoking, excessive alcohol intake, red meat intake. Fiber actually helps, and obesity and exercise are also decreased exercise, I should say, is also a risk factor. Ethnicity actually is somewhat of a risk factor as well, meaning that African Americans actually have a higher incidence and mortality from colon cancer. Moving on, as I said, 45 is the new 50, so make sure everyone gets screened at age 45. If there is a family history or other risk factors or any symptoms such as changes in bowel habits, rectal bleeding, please go to your primary docs, let them know about those symptoms, as they can be kind of herald signs of development of colon cancer. Moving on, screening options, as I alluded to before. The gold standard is still colonoscopy. I know you didn't want to hear that, but it is still the gold standard. The advantages of colonoscopy are multiple. the direct visualization of the actual mucosa or inner lining being the first and most obvious. The other thing that colonoscopy has over all the other screening techniques is that if we do identify a polyp or a cancer, we can either remove the polyp right then and there and or biopsy the colon cancer itself to get the diagnosis. Yes, there is still a prep. Yes, they're not pleasant. However, there are even options for that. These days, there's multiple things, such as actual ones that taste okay. I'm not going to say good because they don't. There is a pill prep as well. Yes, there's pills, but there's 24 of them, so you should know that as well. You take each one with a glass of water. We will work with you in terms of what works for you. So my office routinely offers at least 4 to 5 different preps, depending on whether you like volume, taking pills. So we will work with you on that, make it as pleasant of an experience as possible. Having said that, I always tell my patients it is one day out of your life, and it can save you a lifetime. Other tests that are not as appealing or not as good, so to speak, as colonoscopy, a fecal occult blood test. This will oftentimes be ordered by your primary care physician, or what's called a FIT test, which is similar to fecal occult blood, but it's specific to detecting human blood in the system. I'm sure you've all seen that little box that knocks on your door. That would be called Cologuard. Cologuard is an important screening technique as well. It is certainly not what colonoscopy is. It does not directly test. And if you listen to what that little box says, he actually misses 8% of actual colon cancers. So yes, he detects 92, but he's missing 8% of actual cancers. Having said that, people that are not a candidate for or really have had a bad experience with colonoscopy, at least it's something that they're doing. So I can't completely rain on the little boxes parade. The advantage is it is a home test. It is a little bit more sensitive than the fecal occult blood test or the FIT tests, but it does incorporate both of those technologies into its panel, in addition to a part of it which actually detects DNA associated with colon cancer. The only unfortunate part, and one of the things that's never talked about, is the Cologuard is if it's used as a screening test and it's positive, that counts as your screening now, meaning that your copay for a diagnostic now colonoscopy could be up to $500 to $600. So they'll be careful if your primary care suggests that, because you may be on the hook for a larger copay when you get the diagnostic colonoscopy, I should say. Virtual colonoscopy, you've probably heard a little bit about this. This is similar to colonoscopy in that you still have to do a prep, so know that, to clean out the colon. You then go into a CT scanner where they actually inflate in the colon with air. And basically do somewhat of a CAT scan where they reconstruct it and can actually look inside. Advantages, obviously less invasive. Disadvantages, you're still getting a prep, and you're also kind of uncomfortable during it. They don't give sedation either, whereas we do. So still an important part of the armamentarium of screening techniques, but probably lower on the list in terms of efficacy and accuracy. Once we diagnose colon cancer, how do we, quote unquote, stage it? Colon cancer, if we detect colon cancer on a colonoscopy, first step would be to see us in the office, talk about the diagnosis. We then obtain a blood level for a tumor marker that we look for to go down after a surgery. It's not a prognostic factor, meaning that it doesn't tell you whether the colon cancer is positive or negative, meaning aggressive or not aggressive. It just is a marker that we follow along the course after your surgery. A CT scan of the torso is then performed, meaning chest, abdomen, and pelvis. And most importantly, after all this is done, you should be in with a surgeon that presents at a multidisciplinary tumor board, as we do here at Kaleida. Multidisciplinary tumor boards are about 30 people with different kind of specialties. And what we do is we present each case, all of the data associated with it, along with the person's case itself, other medical problems, and according to NCCN guidelines, tailor a specific and very pointed therapy in terms of your cancer surgery and subsequent care thereafter with oncology. Rectal cancer, very similar. We add an MRI to that to notice stage where we are in terms of how far through the wall the tumor has gone and how many lymph nodes may be affected. The reason being is that rectal cancer is treated sometimes a little bit different than colon cancer. I'd like to explore that a little bit more in the next part of the talk. As many times, if rectal cancer is detected in the lymph nodes on our MRI, we oftentimes will suggest doing preoperative or before the surgery chemotherapy and radiation. This affects the tissues down in the rectum quite a bit. Yes, it kills some of the tumor cells, but it also ends up having a cuff of tissue that is not reliable to sew to, so to speak. Because of that, a lot of times we will perform the surgery. We take a section of the rectum out, put it back together, and then have to kind of hedge our bet. What I oftentimes say in the office is, if you're going to pave a fresh road, you don't want 18-wheelers driving down it immediately. So what do? You detour things. Detour means the dreaded quote-unquote bag, a temporary one. And that's what we're working with here today at Colorectal Health, along with a multi-institutional study to test the efficacy and the safety of a device that a gentleman, Dr. Kim, developed in Korea. He has done animal tests on this. He has done multiple tests in humans, and we were the first ones to perform that surgery here at Millard Fillmore Suburban Hospital. As a matter of fact, it was one of my patients. People that have rectal cancer now have the option of going into a study where we actually implant a balloon tube, which I'll get into in just a bit. The other thing that, before we get there is surgical advances in the last 20 years in terms of colon rectal cancer have been tremendous. I started about 20 years ago. I was doing half open surgery and half laparoscopic. I had to relearn things, unfortunately, but these days our minimally invasive surgery, specifically robotic surgery, has become the gold standard here at Suburban. We do more colon rectal surgery with the robot than anywhere outside of New York City. We have a robust and robotic program, including multiple different specialties, urology, GYN oncology. It's a real pleasure working here, just because I have colleagues that are just as expert as myself and my partners, that if in fact we run into, for instance, a gynecologic abnormality, we can call another physician into the room that is just as expert as we are taking care of colon cancer, to give an opinion and actually jump on the robot and assist us in that way. The advantages of robotic surgery are a multitude. Having done open and laparoscopic surgery, smaller incisions, quicker return to work, less pain, and less adhesions or scars on the inside of the belly. So in general, you're back doing your normal stuff quicker, as opposed to up to 2 months recovering from an open colon surgery. Some of my patients are going back to work after 2 weeks. Instead of 5 to 7 days in the hospital, routinely we have people going home between 1 and 2 days. As far as my career has been, it has been absolutely revolutionary to see some of the advances that we've had. We are proud to have 5 robotic consoles here at Suburban, each at a cost of about $2 million each, and they are busy all of the time, day and night. We're very proud of our robotics program here. Moving on to colon cancer. Treatment depends on the stage and the location. Stage 1 to 3 in general, surgery to take that section of the bowel out, along with the lymph nodes and the blood vessels, plus or minus postoperative chemotherapy if in fact the tumor has metastasized to lymph nodes. Stage 4 metastatic colon cancer will in general just have chemotherapy. There is emerging data with immune therapy, which may be an option in the future. As far as rectal cancer, as I alluded to before, the decision-making is a little bit more nuanced and requires absolutely a multidisciplinary tumor board to opine on that. This is a possible alternative in rectal cancers, or anywhere from 5 centimeters to 15 centimeters above the musculature or sphincter muscles, that actually could save you from the temporary bag. Instead of 2 surgeries, you'd have 1. The colo-BT, as it's called, or colon balloon tube, is inserted during the first stage of the surgery. Instead of having a loop ileostomy at the time, we put this balloon tube in. It then is removed anywhere from 2 weeks to 6 weeks down the line. It protects the anastomosis, or where the hookup, where we have put the colon back together with the rectum, and allows things to, it allows the anastomosis to heal while diverting things very similarly to the ileostomy, but without the bag on the belly. The other nice thing about it is you don't need a second surgery. Really a game changer, as ileostomies are fraught with a lot of complications such as readmissions, dehydration, kidney injury. So this really could be a game changer. I'll show you an example. It is FDA approved, and we're currently undergoing the first steps in the multi-center randomized trial. As I said, it's an alternative device to prevent sepsis in cases of anastomotic leaks via balloon tube placement during the surgery and resultant stool bypass. This is what the tube actually looks like. I'll show you some pictures that are a little more graphic than this, so anyone that's a little gun shy or doesn't like the inside of bellies, please avert your eyes. The tube, as pictured here, is placed above the anastomosis with these 2 blue balloons. They are sutured in place with a Vicryl mesh from the outside of the colon, which holds it in place. We then have a number of ports that allow us to flush the stool from above, and it goes down the protective inner sleeve. There's also a medication port where we can actually test the anastomosis by putting some x-ray dye to make sure that everything is quote-unquote watertight. This has been a real game changer so far. This is what it looks like on the inside. Those are the 2 balloons that I alluded to with the little white Vicryl mesh that holds things in place. That Vicryl mesh eventually dissolves. We deflate the balloons and we pull it out, and you don't need a second surgery. Anyone that's interested in the study that has relatives or friends that may have been diagnosed with rectal cancer, please let us know. We're currently enrolling things. I'd like to thank you for spending this time with me. Hopefully you got a little bit of education and a glimpse of the amazing things that we're doing here at Fillmore Suburban.